Welcome back, everyone. It is my pleasure to introduce our next panel moderator, John Earle. John hosts and produces Mount Sinai's Road to Resilience podcast. John, take it away.
Thank you, Dr. Thompson. It's my pleasure to introduce the next panel discussion, which will explore the mental health impacts of the climate crisis. Each panelist will speak for 5 to 6 minutes, and after everyone has gone, the panelists will field questions from the audience. So please feel free to send in questions as we're moving along. After the panel, we'll move into workshops. We'll have the opportunity to interact with the panelists in a more informal Zoom setting. The aim of this panel discussion is to consider what the research is telling us about the mental health impacts of the climate crisis and what the psychiatric community is seeing in their practice. Now, we hope these insights will help inform clinicians in other specialties. In the interest of time, I'm going to introduce all the panelists right now, and then I will turn it over to the panel. Dr. Janet Lewis is a founding member of the Climate Psychiatry Alliance and is in private practice in the Finger Lakes region of New York State. Dr. Rosalind Wright is co-director of the Institute for Exposomic Research and Dean for Translational Biomedical Science at Mount Sinai. She is an expert on trauma, stress, and health outcomes. Dr. Elizabeth Pinsky is a child psychiatrist and pediatrician in Boston, where she directs the Child and Adolescent Psychiatry Consultation Clinic at Mass General Hospital. Dr. Joshua Wortzel is chief resident in psychiatry at the University of Rochester and a member of the Climate Psychiatry Alliance Steering Committee. And Dr. Cecilia Sorensen is an emergency medicine physician and director of the Global Consortium on Climate and Health Education at Columbia University. We're on a somewhat tight schedule, so I've been asked to gently remind everybody at about 5.5 to 6 minutes so we can keep things moving along and wrap up in time for the workshops. So without further ado, Dr. Lewis, would you please kick us off?
Sure. Okay, well, it's good to be here. I'll be talking both about eco-anxiety and about psychological adaptation to climate change. And we look forward to more time to talk about this in the afternoon workshop. Many of you are familiar with the data from Yale's periodic climate surveys. Most Americans are now either alarmed or concerned about climate change. And over the past 5 years, the proportion of alarmed Americans has more than doubled. The terms climate anxiety or eco-anxiety can be considered umbrella terms, encompassing an array of forms of distress related to climate change and environmental degradation, and also encompassing inadequate coping mechanisms. Importantly, distress over our climate and our environmental situation is not in itself pathological. However, as with any stressor, it can be a facet of clinical presentations and an appropriate subject of clinical work and public health work. This word cloud figure from a scoping review of eco-anxiety articles by Copy et al. Highlights the broad range of vocabulary and phrases in the existing literature to illustrate various concepts related to eco-anxiety. So there's anxiety, anger, grief, despair, paralysis, guilt, pre-traumatic stress. The term solastalgia there in the middle refers to a kind of nostalgia you can have while still at home, when the environment no longer offers the same kind of solace. It combines the Latin word for comfort with the Greek word for pain. There's a research base supporting solastalgia, and if you reflect on it, I think most of us have had twinges of this experience when a cherished place has changed. The existence of all these terms is important because having particular words for experience helps people to process their experience and think more clearly, and it helps to be able to find others who are feeling similarly for support and for work together. And this topic is important to clinicians for 2 reasons. We want to relieve people's suffering, and from a public health point of view, eco-anxiety is important because anxiety can interfere with effective psychological adaptation. And effective psychological adaptation to climate change is what is needed for us individually and collectively. So what is psychological adaptation to climate change? It's a turning toward climate change rather than away from it. in a way that's engaged, in a way that allows for positive affect and a sense of well-being, and in a way that creates mental space to think clearly about what to do, being able to assess and reassess goals and pathways to those goals. I'm mentioning here our multiple crises because this is kind of the elephant in the room. People will often think or say, how can I focus on climate when there are so many things going on, so many crises? This gets called a meta-crisis as our current ways of doing things are coming up against their limitations. But the principles of psychological adaptation also apply to the whole complex of crises we're dealing with in our time of enormous transition. And how we orient ourselves and our patients to climate change is also applicable to how we orient to the whole hot mess. As with any kind of performance, anxiety, even unconscious anxiety, can interfere with all aspects of psychological adaptation. We're all probably familiar with this graph that plots anxiety against performance. Climate change easily pushes us beyond that optimum spot. There are a variety of means of containment for dealing with eco-anxiety. Containment is all about how we bear what's difficult to bear. There are ways of doing this that are adaptive, that are not the maladaptive solution of just not thinking about climate change indefinitely. Every one of these means of containment in one way or another helps us to get to a bigger space, to identify with something larger. And for those who come to the adult workshop, we'll talk more about it. Relational containment is work within supportive relationships with others. This is particularly important with climate, where the problems are collective and the solutions are largely collective. Agentic containment involves focusing on action. Spiritual containment involves leaning on spiritual frameworks and practices. Narrative containment involves identifying with a story, and with climate change, that's usually a story about how we're in a time of great transition. And then there are cognitive means of containment in understanding the larger complex system we're a part of, in understanding that there are hopeful features of it, like the butterfly effect and self-organization in complex systems, understanding things about disavowal, which is a defense mechanism where we both know and don't know something at the same time. We're all in stages of emergence from disavowal, and understanding what's going on with that socially can be containing. And also understanding both and thinking is very important with climate change, as well as being able to engage in reframing of thought in ways that can elicit positive affect without denying reality. So these are the foundations of what help us in psychological adaptation to climate change and to the complex crises of our time. Thank you.
Thank you very much, Dr. Lewis. Dr. Wright, would you go next, please?
Are you seeing that in full view?
Yes.
Yes, we are.
Okay. So just to put a point on the broad scope of impact of mental health implications of climate change, I also wanted to sort of think about mind-body connections and bi-directional connections between the psychological well-being and physical health. And that's what I think about. I think I'm unusual on this panel because I'm not a psychiatrist. I'm a pulmonary critical care physician by training, but I think very much about the interconnectedness between mental health and physical health. And we've heard about why now is the time to be thinking about the health implications of climate change, including mental health, because we have seen such a rapid rise in growing risk factors that are enhanced and magnified by climate change. We've talked about them: air pollution, extreme heat weather, infectious diseases, the pandemic that we're in the midst of now. Changes in allergenicity, which drives a lot of health outcomes in my world, respiratory and allergy. And it has implications for access to healthy foods, but changes in the makeup of the nutrition that we get from our planet. And then, of course, we're emphasizing today the stress impacts of climate change. Now, these We also have been reminded we need to look at this through a health equity lens, because those minoritized populations are already feeling the burden of health disparities in all of these areas, including mental health, but climate change is only going to amplify that. This was reviewed in an invited commentary in Lancet that I referenced there, and you can see more detail on what we're going to be able to cover today. One of the things I want to get back to too is thinking about critical windows. When are people particularly vulnerable? We've heard about both ends of the life course, early life, and as well as the elderly, for example. When we talk about the stress health effects, and we just heard very nicely about that in the previous speaker's talk, this is what I usually think about, is how stress gets biologically embedded to influence not only mental health, but also more broadly impacting health systems. And that is through disruption of key regulatory systems, which are shown here. We often think about the hypopituitary adrenal axis, but this interacts with autonomic function, immune function, and antioxidant-oxidant balance in the body. Now, for those of us in environmental health who are thinking of some of the other risk factors that are enhanced by climate change, like air pollution, for example, that also push and pulls on these same systems. So you can start to see the synergistic effects between the stress that we feel related to the climate change, as well as the environmental, physical, chemical toxins that are going to be increased. And when you think about that from a life course model, what we've been most interested in is trying to capture people as early as possible to the impacts so that we can prevent disease. So we're going to go back more towards early part of life and think about that. But this schematic suggests to us that we need to think about the health effects all along the disease natural history spectrum. When thinking about the health effects early on in starting to enhance risk for mental health outcomes, it goes all the way back to the womb. We have to start thinking of how the child's brain is developing in utero, how mothers impact from these climate change health risk factors is impacted, because we know that mom's psychological functioning, physiologic correlates of such, as well as the stress that she actually is experiencing during in utero development of these children, is already starting to impact brain development and risk for mental health outcomes in these kids, as well as interacting, again, as you see on the left-hand side of this model, with chemical toxins. And we're actually very much involved in trying to understand early markers of that risk. Why is mom's psychological functioning going to be so important? Starting in utero, it's already been linked to a number of adverse physical health outcomes, not just mental and behavioral functioning in the kids. So such that mom's stress during pregnancy, psychological correlates, mom's anxiety, we heard a lot about how that's going to be driven by climate change and only enhanced, actually has impact on development of things like childhood asthma, which is one of the most common and costly diseases in early childhood. And you could talk about this for almost any disease outcome that you can think of. Not only is mom's psychological functioning going to be important to that in utero environment, but actually building resilience. We've talked a little bit about that through some of the discussions today in young children, really starts with that early caregiving environment. Those primary caregivers, moms and dads who are delivering care to these infants, they are so key to developing resilience in the child's stress response systems already at a very early age, starting in infancy. Sensitive, responsive, supportive care buffers young children from experiencing disruption of these stress response systems. And as quality of care decreases, young children become more stress vulnerable. Well, when you have a parent who themselves are struggling with psychological problems, depression, anxiety, that's going to impact their ability to provide care. So giving resources, enhancing our ability to improve and prevent mental health outcomes in the parents is going to be one of the best ways we can actually protect the kids. So you start to see sort of the ripple effect of all of this is really what we're trying to emphasize here. We actually have shown another thing that we're doing at the Institute for Exposomics here at Mount Sinai is not only to look at risk, but can we actually identify some early prevention or intervention strategies that mitigate risk of these toxins that are going to be enhanced through either it's social toxins from climate change, the psychological stress associated with that, or enhanced exposure to things like air pollution or other chemicals. And we published a paper where we showed that you could actually show that early adversity, stress in the mothers, psychological dysfunction in the mothers was enhancing risk for things like asthma, early asthma in kids followed up to prior to the age of 3, showing they had increased likelihood of repeated wheeze, an early marker of asthma, and also showed it got physiologically embedded because they were already had change in their hypothalamic pituitary adrenal axis when they were assessed at age 6 months. But if parents had maintained warm, sensitive caregiving, you could actually buffer that effect. So that if we enhance caregiving environment in that early period, i.e. protect mom's mental health, all the resources that can come to that, you can actually mitigate risk not only for the psychological and behavioral problems in kids associated with stress and stress response systems, but also diseases like asthma or physical disease. Now, another thing I wanted to emphasize is that we've heard over and over again, there are new things that are coming into the purview that we as clinicians need to become responsive to. We need to think about them as in our purview, because a lot of what happens in climate change and the consequences of climate change, like the pandemic, increased infectious diseases that we're seeing, can bring to bear social factors that we need to be responding to because it impacts health. And one of them is violence exposure, and that's been emphasized through papers that show family violence during COVID-19 expanding beyond what was already epidemic in this country and worldwide, gun violence, things like that. These are things we have to start talking about and thinking of as in our purview as clinicians, and climate change is only going to magnify that. And again, if you go back, you look at this figure that I started with here, all these things on the left-hand side, many of them we wouldn't have thought would necessarily be things that were in our purview to do. We need to be all getting public health training across our different disciplines, as Admiral Levine and others have emphasized today, and actually look at it through this health equity lens to really understand the full scope of impacts of climate change on mental health, but mental health interconnected with physical health only compounds that urgency.
Thank you very much, Dr. Wright. Dr. Pinsky, would you go next, please?
Terrific, thank you. I'm thrilled to have the chance to talk about this topic with you guys. I'm thrilled also to be following Dr. Wright, who may not be a psychiatrist, but I'm prepared to grant you your honorary child psychiatry diploma. I think that this is critically important, child mental health and climate change. I think it's only going to become more critical as the climate crisis unfolds. I'm going to try to be brief, and I hope that some of you will think about joining us for the workshop this afternoon.
Oh, Dr. Pinsky, I think you've muted yourself.
January 2022, and we're still here. I apologize. Thank you. I don't know where you lost me, but so I fundamentally and specifically believe that climate change is a child health emergency, and so I don't need to introduce this group to the health impacts of climate change, and sort of building off of Dr. Wright's presentation here. I would remind people that the burdens of all of these are disproportionately borne by children, right? So 80% by WHO estimates fall on children 5 and under. Kids bear the burden of asthma. They're more susceptible to heat stress, a lot of vector-borne illnesses. They just take more breaths per minute. Impact of malnutrition in them can be irreversible. It's sort of like it's hard to identify a health consequence that doesn't fall mostly on kids. And we don't have a ton of data. I know we're supposed to be talking about evidence here, but I believe that what we have is sufficient, and it's kind of common sense that tells us that mental health burdens are also going to fall heaviest on young people. And we know that we're in the midst of a child mental health crisis in this country. I was sort of pleasantly stunned to see the US Surgeon General identify climate, not just climate change, but inadequate progress on climate change in the introduction to this. This is the advisory on the youth mental health crisis that just came out last month. So when I think in general about the mental health consequences of climate change, you can group them a few different ways. I tend to think about in these categories. And when we think about kids, we can find ways that they are uniquely vulnerable in each of these areas. So there's evidence that kids are more vulnerable than adults to develop PTSD after natural disasters. We have just heard from Dr. Wright about stress, and we know more and more about how chronic stress in childhood and adverse childhood events affect folks across lifespan. And in terms of eco-anxiety and climate grief, thinking back on Dr. Lewis's presentation, kids know perfectly well that their future is hotter, wetter, and less predictable than their parents' one was. So all of these vulnerabilities are really baked into being a young person. And I'm going to call our attention to the last one on this list, to betrayal by adults, because we're going to come back to that later. I know that we have touched on this, but it is so important that I'm going to reinforce. We have to remember that not all youth are equally vulnerable, despite the vulnerability inherent to youth. We talk about climate change as a threat multiplier in a lot of ways, but can't ignore that it's a threat multiplier in terms of these social determinants that are so critical, specifically to mental health. I've said that there's little data. There is some, however, that is emerging. And this paper just came out this fall and is really important, not just because it's big, but also because most of the data that we had up until this point, thinking about disparities, really came from like the global north, from the US, the UK, from Australia. And this study is both big and looked at young people that are really much more representative globally. They talked to young people in the Philippines, Nigeria, Brazil, India. And this is what we see. Young people are really distressed, and it is the betrayal and abandonment by adults and decision makers, which is us, you guys. It is that betrayal that is specifically distressing to them. And here's just a little more data from that study. It's heavy, right? I think it's different for young people, right? The destruction is personal. So I will wrap up, but I cannot leave us on that somber note. I do want to close by acknowledging that, in my opinion, youth are really not victims in all of this. And in many ways, they are the most hopeful part of the story. I do not, the progress that we've made is obviously not adequate, but I don't think that we would have achieved that much without youth activists. And so selfishly, what I would say is we need to figure out how to be the best allies and how to support resilience and coping for these kids if we're going to get out of this mess. I think they're our best hope. And so I hope other people will feel inspired to be thinking about this problem. Thank you.
Thank you very much, Dr. Pinsky. Dr. Wortzel, do you go next, please?
Definitely. All right, let me share. Okay, thank you so much, Dr. Pinsky, for kind of hopefully stirring people up to say, well, what can I do? And I'm here to say that there are things that we can do as clinicians about climate change. So I have a couple learning objectives for us in our short time together. One is to think about how we can reduce our personal carbon footprint, Second, to think about how we can try to educate medical trainees about this topic. And finally, what needs to be done regarding research and advocacy in this space. So we'll start with the first, looking at our professional carbon footprint and how to reduce it. So, in very brief strokes, the carbon footprint of the US healthcare system is large. In fact, it makes up currently 10% of all US greenhouse gas emissions. And while there are many contributing factors to this, including the hospital infrastructure, as well as drug development and dissemination, one thing we don't often think about are our large international conferences, and the impact of these is large. In fact, one large international conference is equivalent to essentially the CO2 emissions of an entire mid-sized city in a week. So in a study we just published last year, we looked at the footprint for the American Psychiatric Association's annual meeting in 2018 and 2019. And these lines represent here the as the crow fly distances of participants from their place of origin to the conference. And we found that our meetings produced in 2018, 20,000 metric tons of CO2, in 2019, 21,500 metric tons. And that's a problem because basically that means each of our conferences, if we average across the participants, is producing 1.5 metric tons of CO2 per person. And the Intergovernmental Panel on Climate Change has recommended that each US citizen produces 1.4 metric tons of CO2 per person per year to try to prevent runaway global warming models by the end of the century. So essentially, we're asking people to use their entire annual footprint just to attend our annual meetings. And so part of what we've done is to try to model how we can reduce that footprint significantly. And it turns out that if you use a hybrid co-occurring regional model, so for example, having people in the Northeast come together, in the Southeast and the West, and then to relay with one another virtually, you can reduce that footprint by 85%. And in fact, the American Psychiatric Association just published an action plan to reduce our footprint by at least 50% by 2030. So there are things we can do. There are also other ways we can reduce our footprint. There have been studies that have looked at the psychiatry residency match, and actually more broadly, just the residency match in general. But in psychiatry, we produce 13,500 metric tons of CO2 annually, and that's completely eliminated by use of virtual interviews. When it comes to car travel to outpatient appointments, it turns out in psychiatry that on average, probably across the country, we produce around 120,000 metric tons of CO2. And just by holding 17% of those appointments through televisits, we would be saving the equivalent of a whole APA annual meeting worth of carbon footprint. And then there's also ways of reducing our infrastructure. So, I would recommend that you check out organizations like My Green Doctor to see how you can make your own personal practice greener. So moving on to how to try to educate medical trainees about this topic. Well, currently, unfortunately, not many medical trainees learn about this issue. In fact, we just completed a study looking at psychiatry residencies and fellowships and found that only 13% of them have any didactic material on this topic. Counter to that, though, we find that 70% of trainees in psychiatry are thinking that climate change and mental health is very important to essential to learn about. So we have to bridge this gap. And I'll say that I'm very pleased to be preceding Dr. Sorensen, who's going to be talking about this, but there are organizations putting together curricula on this topic. And I would also encourage you to check out your individual medical associations, because I know the American Psychiatric Association is developing content on this as well. And then finally, what needs to be done regarding research and advocacy? So we looked specifically at research in child psychiatry as it relates to climate and mental health, and interviewed experts in the field and found a couple themes. One is that understanding and also developing therapies for eco-anxiety is paramount. And just as Admiral Levine said, we need to really devote energy to that. We also need to develop more interventions to improve resilience in our parents and communities to help support children facing climate change. And then we also need to be more interdisciplinary. Currently, we operate in a very silo-driven system of research. Someone's an expert in trichotillomania, but we're going to have to become more systems-based in our approach. And then finally, with advocacy, I also encourage you to check out what your specialties may be doing. I know in psychiatry, we have the Climate Psychiatry Alliance, as well as the newly established Climate Committee that's part of the APA. So takeaways from what I've said. One, we can reduce our professional carbon footprints through thinking creatively with our large international meetings, with how we hold our residency interviews, with how we even conduct our clinical practice. We need to educate medical trainees on this issue. This is something that's not really being done, but many medical trainees want to learn about it. And finally, we need to conduct more research and advocate more for the effects of climate on mental health. So these are some of the references that I had discussed, and I'm happy to stop sharing and hand it over to Dr. Sorensen.
Thank you, Dr. Wortzel. Dr. Sorensen, take it away, please.
Thank you so much. Let me get my slides up here. Thank you. Really, really exciting to be here today with everyone and to listen to your presentations. I'm learning so much. So my goal today is to briefly share how the mental health impacts of the climate crisis are being seen in the emergency department. I am by training an emergency physician, and to share some ideas for how we can really, at the bedside, increase the resilience of our patients and communities through the healthcare that we provide in acute care settings. So in many ways, I think of EDs across the country as really being like the ground zero for climate-related health impacts. And this is especially true for mental health impacts. Nationwide, there are an estimated 131 million ED visits annually, which equates to nearly half of all US medical care which is provided. And so because of our role as this default provider, and really a provider for sort of all comers and a safety net provider, we see the full scope of climate-related health impacts. And this is especially true for mental health impacts. And current evidence suggests that mental health emergencies factor into at least 1 out of every 8 ED visits. And if we glance at this list of acute and chronic mental health impacts from climate change, we see that many of these issues we frequently see in our ED care, either reflected in the chief complaint or as contributing factors. And we really need to think about how we can address these issues and really factor them into the care that we are providing at the bedside. So just to give a quick example, we know that climate change is increasing the prevalence of extreme weather events. In 2020 alone, there were nearly 2 million people who were forced from their homes in the US, the majority of which were from climate-driven disasters. We know that forced displacement and loss of livelihood and community stability are associated with the increased risk of PTSD, of depression, of anxiety, and substance abuse, which can really persist for years among survivors. Additionally, we know that weather-related disasters are associated with an increased risk of interpersonal violence. And so whether or not you live in an area that has been recently or even not so recently affected by a climate-related disaster, it doesn't matter because we are going to end up taking care of these patients. So we're looking at a map here of displaced survivors from Katrina. This is old data, but if you look at where the impact of the hurricane was, and then where people ended up scattering after the hurricane, we realized that we are going to be seeing these patients, as far as in Washington or in Maine, who have been affected by disasters. So wherever we are, we really need to be ready to care for them. And, so for these patients who have been displaced, the ED becomes this primary point of access, both for general medical care as well as for access to the mental health care system. And so in order to make a difference, we really need to make the diagnosis. And this means having mental health on the differential. Now, in terms of how this applies to our bedside care, I think this really means, getting serious about screening for SI, screening for substance abuse, and for home safety and interpersonal violence. At this first point of contact, we can also really increase our repertoire of bedside strategies to respond appropriately. For example, by applying strategies related to mental health first aid. This is not a skill we necessarily learn in our residency training programs, especially as general medical providers, but there are a lot of really useful and helpful skills that we can learn in regards to mental health first aid. And there's a lot of courses out there, which I can point you to if you want to shoot me an email after this. The other thing we can do is what we really need to do is work closely with our clinical care team, with our social workers, to really connect patients with appropriate mental health and social resources, and think about that as the wraparound care that we're providing in the acute care setting, even in emergency departments where everything is so chaotic and so busy. Teamwork is really the way we're gonna get through this. And we also need to think about our role as advocates for patients, right? How can we really, help them understand their own stories and understand the help that they need and help them get that help. So on a related note, we know that climate-related exposures also exacerbate risk for many patients who have existing mental health illnesses, and that these can contribute to their presentations in the ER. So for example, it has been found that during heat waves, hospital admissions and ED presentations increase for mood disorders, for stress disorders, somatoform disorders, and for schizophrenia. And furthermore, evidence has suggested that pre-existing psychiatric illness can more than triple the risk of death during a heat wave. So our mental health patients are an incredibly vulnerable demographic as it relates to climate exposures. So there are really two main issues concerning the effects of heat on psychiatric illness. First is the nature of the psychiatric condition, which can be a risk factor for heat-related morbidity and mortality. And second, heat can be a risk factor for the exacerbation of the condition. So for example, many medications used in psychiatry can actually increase vulnerability to heat by impairing the body's ability to thermoregulate, decrease your ability to sweat, and or increase your internal heat production. Additionally, some of these medications and the nature of the mental illness itself may alter a patient's cognitive awareness of the environmental conditions and impair their ability to take adaptive measures such as increasing fluid intake and seeking a cool place. So the main classes of medications that I think about are antipsychotics, anticholinergics, SSRIs, sedatives, and mood stabilizers. So I kind of think about this as my box of medications to really think closely about, especially during warm months and especially during heat waves when you're prescribing them or when you see them on a patient's medication list. So at the bedside, there are several steps we can take, to counter these impacts. The first thing is to be very aware of what medications your patients are taking. The second would be to, really increase the index of suspicion for heat illness among mental health patients who are presenting with exacerbations. If someone with schizophrenia is presenting with behavioral disturbances, psychosis, are they also experiencing some degree of heat illness? And are we addressing that? Are we considering that in our differential? The second point I want to make about bedside care is that we really need to be very cautious about prescribing any of the aforementioned classes of medications, especially during heat events and in warm summer months. And three is to really think about having a safety plan for mental health patients being discharged to the community, especially during heat events and especially during summer months. Thinking about, who are the case managers involved in their care, where are they going after leaving their ER, and are they aware enough, do they have enough competency to be able to understand the risks of the medications that they're on. So not to add to the burden of the work we already do in the acute care setting, but I thought these were some strategies that we could sort of add to our repertoire of how to increase resilience among our patients and among our communities. So thank you so much, and I look forward to the discussion.